So this is where we launched what we call ThriveNYC. At that point, it was just a report. Now we have 54 initiatives up and running. The first 4-year cost of about $1 billion. You can't solidify the workplace, secure neighborhoods, figure out your prison problems, graduate everyone you want to graduate, reduce your healthcare burden if you're not taking on mental health in its fullness. Maybe 1 out of 5 Americans who have major depression will get evidence-based care for it. So there were 2 realities we wanted to take on. The mismatch between the size of the problem and the approach, and the mismatch between our reliance on a treatment system that just wasn't reaching people and living up to the challenge. There was the diligence with widespread community input, to decide what were our North Stars, what were our guiding principles. Change the culture included everything from training 250,000 New Yorkers in mental health first aid to training half the New York Police Department in how to manage behavioral emergencies on the street. Act Early were whole new investments in socio-emotional learning across our public pre-K and daycare centers that touch 100,000 kids every year in socio-emotional learning skills, close treatment gaps, and we identified some key gaps we wanted to close, such as universalizing screening and treatment for pre- and postpartum depression, partnering with communities, doing place-based work for this ensemble of stuff to really work and to really be sustained and permanent and to see their impact. Use data better. Created a whole new thing called the Mental Health Innovation Lab in our health department to come with new sources of data, and we're exploring crowdsourcing and learning about gaps and needs through push surveys and pooling data sets that never talk to each other. And then finally, position government to lead. For government to do these 54 initiatives and to do this approach, it has to change in the skill sets it has, in the structures it has, in the data it has, in the way it engages with the communities that it oversees, that it governs. So we created new structures. We created a mental health planning council that brings multiple city agencies together. So you have Parks Department, probation, police, child welfare, economic development, all talking about how they are all working towards shared aims around mental health. So what I just described to you is sort of where we started, with a commitment for a principle-driven public health approach to mental health. By public health, I mean what also informed the initiatives were looking across the population, who's affected, where are key risk opportunities to intervene. But there are 3 other things I just want to briefly mention that we learned as cross-cutting ways of implementing this stuff. They are explode the work, and explode the workforce. To do those initiatives, we have to totally rethink the workforce, who's in it, what skills they have, how they relate to each other. We need to engage the city, and I mean that in a very deep way, and I'll talk a little bit more what I mean by that. And we have to learn. It's not the external party coming to do the 3-year evaluation that gets reported at the end. That's not where learning happens. The learning happens in the day-to-day effort to make this work, and that's where we lose most of the really precious data about how to do this. So we have to equip our front lines to be laboratories through improvement practices, through other embedded and facilitated supports for them to do that. And we saw that as a mission of the city. It's engaging the city into this work at all levels. It's not just the business of the health department, and it's not just the business of government. Most of the Thrive initiatives that are funded, the 54 initiatives, actually are owned or co-owned by agencies other than the health department. And we found in New York that also, if you travel, if you step out, you start to find what the healthcare system is not finding. So the data at the bottom right is from a colleague of mine who did a convenience sample of churchgoers one day in a black church in Manhattan, and used the PHQ-9 and found these depression rates, which are higher than you find in primary care, about 3 times what you find in the general population. So if I'm a public health planner, if I'm coming in from a public health perspective, my priority is making sure priests know what to do, is to go to churches to find the people that we're missing. And so if you put all these things together, you really have a very different topography of how you are thinking about your mental health system. It's not in your centers. It's partly in your centers, but they have a different role. They're there and task shifting mostly to skill build, coach, and mentor others to be front lines, as well as to get more serious folks who need specialized care. My last message to you is, if you're going to think about how to think at a population level, is to have permission to speak exceptionally about the completeness of the work that you need to do to succeed and the strategic anchors you have to be honest to if you're going to succeed before things get unleashed. It's proven very helpful to us. It's kept us honest, as sprawling and as nerve-wracking, and I can tell you as many crises every day we have on each of these 54 initiatives to keep track of, but it keeps us on a strategic direction and a hope of strategic fidelity to these kinds of transformative possibilities. Thank you.